Hello, featured nurses. This is Professor Flourish. Today we're going to talk about cardiovascular diagnostic and therapeutic procedures. Like always, I kind of like to start with just some general reminders. So as you continue on in the cardiac chapter, keep these things in mind. The first one is to make sure to assess your patient. These machines are only as smart as the person analyzing the results. So you want to make sure that you are comparing results with previous blood pressure readings, with previous vital signs, that you're assessing your patient's pulse, that you're looking at their level of consciousness. So you always kind of want to make sure that you're looking at the patient as well as things like the tele, so the lead placements. So like I said, always compare your results of previous readings. Remember that we look for trends of our patient first and most importantly, because if we've got a patient who's consistently bradycardic and there's nothing that's causing that bradycardia, then I'm not going to be nearly as worried as somebody who goes from a heart rate of like 100 down to a heart rate of 30. So kind of keep these things in mind and always look for your trends, especially when you're in clinical. Kind of make a habit of it to see what was my patient like yesterday compared to today. So our cardiovascular diagnostic procedures, what they're doing is they are used to evaluate the functionality of the heart. We use these to monitor enzymes in the blood. We use ultrasounds to visualize the heart, which can help determine the heart's response. And we also do a stress test, which helps determine the heart's response to exercise. And then we use catheters to determine blood volumes, perfusion, fluid status, and how the heart is pumping and the degree of artery blockage. So these are all various diagnostic procedures. So on here, like we talked about in class for our procedures, we've got both diagnostic and therapeutic. A diagnostic test is basically just kind of giving us information. A therapeutic test procedure, what it is doing is trying to fix a problem. So whenever you see diagnostics, we're thinking of assessment. Therapeutic is thinking of an intervention. So our diagnostic tests are things like our cardiac enzymes and lipid profile. Both of these are blood tests, our echocardiogram, our stress test, our hemodynamic monitoring. So we're going to talk more about the advanced hemodynamic monitoring opposed to the ones that we typically do first semester of nursing school, which is things like our blood pressure, our angiographics. And then for our therapeutic, we've got a central vascular IV access placement in our precutaneous coronary interventions. So the first thing we're going to talk about is our laboratory tests. So we'll talk about our cardiac enzymes, which is a blood test. These enzymes, if you remember what an enzyme is, it's basically kind of like a little helper that makes things go faster. So with these enzymes, they're released into the bloodstream when the heart muscle suffers ischemia. On the next slide, you'll see a picture that shows the difference between ischemia and infarction. So kind of keep that in mind when you're studying these things. So these can be specific markers in diagnosing a myocardial infarction. A myocardial infarction, in layman's terms, is your heart attack. And like I said, ischemia is diminished blood supply to any tissue or organ of the body, which can cause that shortage of oxygen. So on here, we've got ischemia versus infarction. And I just wanted you to keep this in mind as you continue onwards because it'll help you. Ischemia is blood flow is decreased. That means I'm not getting as much blood flow. So it causes hypoxia, insufficient oxygen. So if you look through here on this picture, it's shown through the blue. And with this tissue we can still save. So that's why the first thing that'll happen is ischemia. Infarction means that the blood flow is cut off, which causes necrosis and cellular death. All this gray area here indicates that this tissue is no longer alive. We cannot save this tissue anymore. So some of these enzymes that we were talking about, like I said, this test can indicate the death of myocardial muscles sometimes, and it can show a heart attack. So the first one is your CKMB isoenzyme, which usually increases within 4 to 6 hours following an MI and remains elevated for 24 to 72 hours. So this one, you can see if the patient has had a heart attack within 24 to 72 hours. Your troponin is a protein that is considered the gold standard in diagnosing an MI. It remains elevated from 2 to 3 weeks following an event, and normal level is less than 0.2. So because it has that long time frame, that's why it's our golden standard. So when somebody comes in with chest pain or somebody comes in with ST elevation, one of the first labs your doctor or provider is going to order is usually a troponin along with the CKMB. The troponin is because they want to see, has this lasted for 2 to 3 weeks? The CKMB is because I want to see, has it happened in the last 24 to 72 hours? Myoglobin rises early in response to tissue injury, so this is usually within the first 2 hours. So if you have somebody who had an active heart attack or an active MI, you'll usually see that rise. But the issue is it declines very quickly after 7 hours of injury. So it is less useful than your CKMB or your troponin, since myoglobin is present in both skeletal as well as cardiac muscles. So your lipid profile blood test, this one is more like your precautionary tale. So these are ones that we do before there's an active emergency. So this is like when you go to your primary care physician, when you go there, a lot of times they'll check your cholesterol because we want to see what's going on with you. Because if you have a lot of cholesterol, it's going to block your arteries, which can lead into a myocardial infarction. So like I said, this provides information about your cholesterol levels, and it's used for that early detection of heart disease. These are some more just general tests. We've got our coagulation tests, which we have a PTT, which is most significant if the patient is on heparin, your PT, which is most significant if your patient is on warfarin or Coumadin therapy, and your INR. You've got your BNK, which we'll talk about more when we get into heart failure. And a critical value there is greater than 100. And then your BUN and creatinine, which both reflect your renal function and perfusion. So these levels may increase in your MI, congestive heart failure, or cardiomyopathy. This here just came from your book directly. What it shows is just kind of elevations and your increased risk for coronary artery disease. It's just a helpful chart to kind of keep in mind while you're studying. And like I said, that troponin is definitely our golden standard. So whenever we're dealing with myocardial infarctions, you just want to remember, okay, troponin is what I'm looking for. If that's increased above that 0.2, I'm very concerned. So one of the first diagnostic tests we're going to talk about is your transthoracic echocardiogram. And like I said in class, I really want you to know the difference between a TTE and a TEE. Mostly because this is more for when you go into clinicals, when you go into your practice, you want to know the difference. I tried to put enough pictures on here so you can kind of see what it looks like. So a TTE is used to diagnose valve disorders and cardiomyopathy, can evaluate the size, shape, and motion and structure of the heart, measures ejection fraction, which we'll talk about on the next slide, and it is non-invasive or minimally invasive and uses a device on the chest to capture pictures. So this one is usually typically if your doctor is concerned about your heart health, then he'll order this TTE. We don't have to put the patient under, and since we're not putting the patient under, there's no informed consent that's needed for it, and you're basically just kind of taking a picture of the heart. So your ejection fraction, which is also known as the left ventricular ejection fraction, is the measurement of the percentage of blood leaving the heart each time it contracts. So it's a very helpful tool to let us know how much blood is my patient getting, how much is pumping through all my vasculature. Some of the indications for this test might be things like heart failure, cardiomyopathy, angina, and MI. So now you might be asking yourself, what is my role during this? So you'll see this very typically with me. I like to put your pre-procedure, intra-procedure, and post-procedure. So your pre-procedure is you're going to explain that this is a non-invasive test and may take up to an hour. So you want your patient to be aware that they're going to be laying on that left side for a while. During the procedure itself, you want to instruct them, like I said, to lay on their left side and to remain still. Now, sometimes during this, depending on what the doctor has ordered, you may be requested to give contrast, or you may be requested to do what's called a bubble study. A lot of times the tech that comes in to take the TTE will kind of walk you through what they need done during those different image portions. Now, what I will say, since contrast may be given during it, you want to read your order set and see if it's with contrast. If it is, make sure you are assessing your patient. Are they allergic to contrast? Are they allergic to shellfish? Anything of that nature. Post-procedure, provider reviews test results and a plan for follow-up care with the patient. So the next one is your transesophageal echocardiogram. So this is your TEE, so your T. So this one provides a much clearer ultrasonic image because the waves pass through less tissue. So this one, like you see in this image here, is actually going to go through the mouth, down through the esophagus to look at the heart. Now, since we're putting something down somebody's throat, these patients are going to be under when we do this. So what happens is a small transducer is passed through the mouth and into the esophagus to provide those images of the heart. Some of your indications can be things like heart failure, valve heart disease, arterial or ventricular thrombi. You also use it during valve replacements and coronary artery bypass surgeries. So for this one, pre-procedure would be things like ensuring that informed consent has been signed, instructing the patient to be NPO for 6 hours prior to the procedure, and inserting that IV access. So with this, what you want to remember with your informed consent, we're not explaining the procedure itself. We're making sure that the patient understands what they're signing. So you just kind of want to let them know. Now, anything that has to do with the nurse, like you can let them know that when they come back, their throat might feel a little scratchy, something like that, because that's something we deal with. But anything about the surgery itself, you want to redirect back to the physician. Inter-procedure, you want to monitor the patient's level of consciousness, their ECG, blood pressure, heart rate, respiratory rate, and oxygenation, because moderate sedation is needed for this procedure. Post-procedure, you want to monitor the patient's vital signs, their oxygen levels, level of consciousness, and return of gag reflex. So that's a very, very important one. Anytime that you have a procedure where they go under, always make sure you're checking that gag reflex before you give them anything to drink. Because like I said, because topical anesthetics are used in the throat, they may have suppressed that gag reflex. You also want to maintain the head of bed at about 45 degrees. So before you give them drinks, anything like that, just make sure, can they swallow? So this is just like a quick kind of what's the difference between these two. TTE is a non-invasive or minimally invasive and uses a device on the chest to capture pictures. TEE is invasive and uses an endoscope down the esophagus to get a clearer and closer image of the posterior cardiac structures. TEE is typically done after TTE if a more detailed image is needed. So the next thing is our lovely stress test. So you can have two different types of stress tests. We've got the traditional exercise stress test, where basically the patients will exercise the cardiac muscle by walking on a treadmill. It provides information regarding the workload of the heart, and the test is usually discontinued once the heart rate reaches a certain rate. We also have a pharmacological or chemical stress test. This is usually reserved for patients who are fatigued or disability that can prevent them from doing the traditional exercise test. So basically what happens is the provider will prescribe this test to be done as a chemical stress test. So they're going to give them medications that's going to increase their heart rate. So the stress test is usually used for things like angina, heart failure, dysrhythmias, MI. Basically, the whole process is the doctor wants to see how's your heart reacting. So pre-procedure, you want to obtain informed consent. You want to explain to the patient that they will be walking on a treadmill, so to wear comfortable athletic shoes and comfortable clothing. For the pharmacological stress test, any of the following medications can be prescribed. You also want to instruct your patient to fast 2 to 4 hours before the procedure. Basically, just follow that order set. You want them to avoid tobacco, alcohol, and caffeine before the test. Basically, we don't want anything that's going to give us false results. And you also want them to have adequate rest before they have this procedure. During the procedure, you may be applying a 12-lead ECG to monitor heart rate during the test. So you're looking for those dysrhythmias. You want them to report any chest pain, shortness of breath, or dizziness. Post-procedure, once again, we're just going to monitor the patient. We're going to check our vital signs, and then the provider is going to review any findings with the patient. This is just kind of like a quick tidbit of what the patient will expect. It's kind of like one of those quick ones that the patient can look at, see it. So hemodynamic monitoring. So a majority of our hemodynamic monitoring up to this point has been things like our vital signs, watching our blood pressure, watching those trends. These ones that we're going to talk about are more of your critical patient monitoring. Now, try not to get too wrapped up in all of this. I kind of want to expose you to this before we go more in depth next semester. So just kind of be aware so that way when you hear things like swan's gaze, you know what that means. So hemodynamic monitoring involves special indwelling catheters, which provide information about blood volume and perfusion, fluid status, and how well the heart is pumping. So one thing to keep in mind, whether we're using these more in-depth monitoring or if we're using our vital sign machine like blood pressure, watch your older adults for how these hemodynamics are affecting their rhythms. Because if you remember, older adults don't have as much blood in them, so you just want to make sure, is the lack of blood causing them to have a dysrhythmia? So just kind of watching these frequent dysrhythmias, watching those hemodynamic effects. Okay. This video here, I'm obviously not going to watch it right now because it won't actually allow me to, well, it will allow me to watch it, but you can't really hear it. This video is on momentum, and it just kind of goes through what a swan's gaze is. It's very informative because I like how it actually shows you the location of it. And the whole reason I show you this is because I want you to keep in mind that this is going directly into the heart. So when you manage these type of lines, make sure that you're watching for infection. Make sure that you are keeping a very sterile field when you're changing your dressings with this. Make sure you're watching for things like embolisms. So just kind of keeping in mind of how serious this line really is. So yes, complications can be things like infection, sepsis, your embolism, all those kind of situations. So you want to avoid introduction of air into the flushing system to prevent air embolisms. So just make sure that when you use your saline flush, that there's no air in it whatsoever, because there's a lot less wiggle room when you push it into a swan's gaze, because you can use it for medication as well as using it to monitor. All right, so now we're going to talk about our invasive cardiovascular procedures. So cardiovascular procedures can include these invasive methods that are used to improve blood flow for occluded arteries and veins. It's indicated after non-invasive interventions have been tried. So most physicians and most providers, they're going to try things like diet, exercise, medications before we jump into these more invasive procedures. Procedures can include things like your percutaneous coronary intervention, PCI, coronary artery bypass grafts, CABG, and your peripheral bypass grafts, which I believe you guys talked about these peripheral bypass grafts last semester. So coronary angiogram or angiography is your cardiac catheterization. So this is an invasive diagnostic procedure, which is used to evaluate the presence and degree of coronary artery blockage. It involves the insertion of a catheter into a femoral, brachial, or radial vessel and threading it into the right or left side of the heart. Dye may be injected to visualize the blockage, which can be treated with your PCI. Coronary artery narrowings and or occlusions are identified by the induction of contrast under fluoroscopy. So basically what happens is we introduce a catheter into one of these arteries, and we send basically like a lack of better terms, like a little tube all the way up to our heart so we can actually visualize it. If there's a lot of plaque there, then a lot of times what the doctor will do is just go ahead and break off that plaque if they can. If it's so occluded that balloon pumping, that doing these different types of things, like not even a stent will work, that's when we move on to a cabbage. So this, like I said, percutaneous coronary interventions, a non-surgical procedure performed to open coronary arteries through one of the following means. So we can have an atherectomy, a stent, or a percutaneous transluminal coronary angioplasty, which I've got all the explanations here. So with your atherectomy, so arteriolectomy, it's used to break up and remove plaques within the cardiac vessels. So what they'll do is they'll kind of send that up there, and then they're going to literally kind of clean out the plaques. So it's almost like as if you were, you had a hose that was filled with dirt and you're just kind of scraping it away. It's like if your sink was clogged and you can kind of clean it out. Percutaneous transluminal coronary angioplasty. With this one, a balloon-tipped catheter is used to press the coronary blockage open to improve blood flow. So it's usually typically called an angioplasty, and as you can see here, they're using a balloon to basically break this up, opposed to with the arteriolectomy, where they're going to kind of scrape it off. This one's just kind of using that balloon and popping it. A coronary stent is a procedure performed during angioplasty that leaves a metal mesh in place as a structural support to prevent blockage from reoccurring. So if they can't just break it up with the angioplasty, instead they're going to put this little mesh stent here that's going to force the vessel to be open. So depending on your cardiologist, you can get some of them that are very, very good at stenting things, and it keeps the patient from having to have a cabbage. With this, though, you need to make sure that we're giving good education about the follow-up medications, because you don't want them to reocclude this vessel. I like this picture here. It's like the same picture I just showed you because it shows a very straightforward assessment of this. So patients who need cardiac catheterization need to be in the cath lab within 90 minutes of ED arrival for best patient outcomes. So 90 minutes. So when you're thinking about this, you want to make sure that you know what time your patient arrived to the ED and how much time you have. So for example, if a patient came in at 3 p.m., what time do you want them to be in the cath lab? I'll give you some time to think about it. You want them to be there at least by 4:30 because you want them to be there within that 90-minute time frame. So get used to your clock, get used to knowing how much time you have, especially those of you who want to work in the ER. So these are some of our indications: unstable angina and ECG changes. It can confirm and determine location and extent of heart disease. So this procedure can be more of a diagnostic. It might reduce ischemia during the occurrence of an acute myocardial infarction by opening up coronary arteries and restoring perfusion. So now that's more of a therapeutic procedure, and might be used as an alternative to coronary artery bypass grafts. This is so true. So when I was working in cardiac, you wouldn't believe how many patients were saved just by this one procedure, because we were able to open up vessels, able to save them from having to do open heart surgery. So depending on the location will be the kind of care you give. So they have different access points. Your access points include the femoral access, radial access, and brachial access. Now, all of these are arteries that they're going to go into. And when you're looking at this, what I want you to think of and what I want you to remember is how big are these arteries? So, for example, your radial access point are typically pretty stable upon returning to the cath lab. So, and that's mostly because they're not going to really do too much. This is usually used as a diagnostic procedure. So they go in and kind of look to see what's happening with the patient's vessels. A FEM location, on the other hand, this is when you're going to have all of those precautions. This is where you're going to want to keep their legs straight, everything of that nature. Because this one is a much bigger vessel, so there's much more likely to bleed. With this one, the good thing about a FEM access is that you can actually put stents in through here because it's a bigger vessel, so we can put more through it. So just kind of remember that, especially when you're going through your questions, make sure that you're reading what type of access point they had, because depending on the access point is what we want to get done. Because if I had a radial access point, do I necessarily need to keep my leg straight? No. I need to keep my arm down, my arm straight, but I don't need to worry about my leg. So what's more important here is making sure I monitor my vital signs every 15 minutes. So like I said, the bigger the artery, the more likely to bleed. So just make sure you're keeping note of the size of your arteries that they're using and which access point they used. So before you do your procedure, you want to make sure that you're doing the following. You want to maintain NPO status for at least 8 hours due to the risk of aspiration while laying flat. Obtain vital signs, also take heart and lung sounds, and assess peripheral pulses. Sorry. So this is a very, very important step. And just take a moment to think to yourself, why do we think that this is such an important step? Baseline. I want a baseline of what's happening to my patient. I want to know what their vital signs were. I want to know what their heart and lung sounds like, because if there is some sort of complication, I want to know what they sounded like before they went in, and my peripheral pulses. If they had a weak pulse before going in, I would expect a weak pulse after. However, if they had a strong pulse, then I expect a strong pulse. And if I'm seeing a weak pulse, then there's an issue that happened. Ensure that your consent form is signed. Always make sure that you have that consent because it's a liability. Ensure the patient and family understand the procedure. So this goes into that consent form. You just want to make sure, does the patient understand what's happening? Assess for iodine and shellfish allergy, because they will be using contrast media. So if they tell you that they have a shellfish allergy or they're allergic to contrast, let the physician know. I cannot stress enough about how important it is for allergies. Always let surgery know if somebody has an allergy. It's a very serious thing that we need to take in consideration. Assess renal function prior to the induction of contrast. If they've got a pretty bad creatinine, you want to let the doctor know, mostly so that way post-procedure, they might order something like fluids to clear out the kidneys. If patient takes metformin, you want to ask the provider about withholding that prior to and following the procedure. And it can be up to 48 hours because metformin can cause hypoglycemia or acidosis when receiving iodine media. So these are some things to tell your patient pre-procedure. So a mild sedative will be given to promote relaxation and local anesthetic. The groin is the most common site for the procedure. Sensations of warmth or flushing may be felt. After the procedure, pressure is typically held at the site. So just kind of letting them know these things. Intra-procedure. So this is, you are in the cath lab. You are the nurse working in that situation. So administering sedatives and analgesics as prescribed, a lot of times this falls on the CRNA, but just kind of being mindful of these things. Monitoring your vital signs, heart rhythm, and chest pain, including unusual discomfort. So this is the really big thing. These patients in the cath lab, they can talk to you. And if all of a sudden the patient says, I'm just feeling something that I don't usually feel, this is unusual, make sure you're letting the doctor know. That is your highest priority at that point. Warm flush feeling, normal. because that is the contrast one. Urge to cough, normal. Pressure at the incision site, normal. Those are all normal things. You would expect them. Abnormal things are chest pain or anything that's unusual from what they should be expecting. Be prepared to intervene for dysrhythmias. Have your emergency equipment and medications readily available. So now we've got the sheath removal. So they just finished their procedure and now we're actually removing the sheath. So a catheter sheath is short, hollow tube that's placed inside the artery or vein at the insertion site. If a percutaneous coronary angioplasty is performed, sheath is used as a guide for a balloon catheter. After the angioplasty, catheter sheath can be left in for access. So sometimes, depending on the floor that you work on, they'll either remove this in the cath lab or they'll send the patient to either the unit or to the general cardiac floor where you'll remove it there. So you want to observe the patient for vagal response, hypotension, bradycardia from compression of nerves. Apply pressure dressing and withhold administration of metformin for 48 hours after your angiography. So whenever I would pull these sheaths, what I would do first is I would find my pulse. So I'd find that, because it was usually for your fem arteries are the ones you get more concerned about. I'd hold pressure and then I would have someone else feel the pulse down below, and then we would pull it out, and you'd usually hold pressure for about anywhere from 15, 30 minutes, depending on how much they're bleeding. Yeah. So post-procedure, this is after we've got the sheath out. These are what we're going to watch for the patient. So sheath is no longer there. We are now, our patient's just kind of resting until it's time. You're going to assess vital signs every 15 minutes times 4, every 30 minutes times 2, every hour times 4, and every 4 hours. Now, some doctors may have them on for longer, some may have shorter, but usually as soon as that sheath comes out, you're going to do that every 15 minutes, and then every 30 minutes, then every hour. So it's like a continuous thing. And when you do these assessments, you're not only doing vital signs, but you're also assessing the extremity, and you're also doing a quick level of consciousness. So when you're assessing that extremity, you want to look for bleeding and hematoma at the insertion site and looking for any types of thrombus. Make sure you are documenting the pedal pulse, extremity color, and temperature. So you're looking at all of these things when you're checking it. Loss of a pedal pulse needs to be reported immediately. So anytime you see immediately, make sure you're putting that little star on your notes, because that is a need to know. If you cannot get the provider, then try to get rapid response. So loss of that pedal pulse or any sort of change in the color or temperature of the foot are things that you want to look for. You also want to do cardiac monitoring for any dysrhythmias, because sometimes with that reperfusion, you can cause the patient to have a dysrhythmia. Maintain bed rest in a supine position with extremities straight for prescribed time. So the supine position is more if you've got those lower fem ones. If you've got a radial access point, then you're just going to want to kind of keep the arm as straight as you can. A vascular closure device can be used to kind of hasten that hemostasis following the catheter removal. Older adults can have arthritis, which can cause that laying in the bed after the procedure to be painful. So you may want to talk to the provider about maybe getting some Tylenol or something while they wait. Monitor your patient for signs and symptoms of cerebral vascular accident. So immediate intervention needed. So if your patient is showing things like slurred speech, that's one of those, put a star next to it, immediate intervention is needed. Anything that's showing a change in their neurodevelopment. You want to monitor your urine output and administer IV fluids for hydration. So this is some of your patient education when they're getting ready to go home. So you want them to leave the dressing in place for the first 24 hours following discharge. It just helps hold a little bit more pressure, so that way we don't have that risk of bleeding. You want them to avoid strenuous exercise for a prescribed amount of time and immediately report bleeding from insertion site, chest pain, shortness of breath, and change in color or temperature of the extremity. So even when they go home, we're still being cautious. Are they having any chest pain, shortness of breath, anything like that, which would cause them to come back to the ER? You don't want them to lift any more than 10 pounds, and you don't really want them to bend at the waist or strain for at least 24 hours. Resume metformin as prescribed. So depending on when they did the procedure is when the doctor or the provider will let them know when they can start taking their metformin again. If the patient has a stent, make sure they're taking their antiplatelet therapy as prescribed. So this is a big thing because what we don't want is that reocclusion. So making sure that we're giving them good education on, yes, continue your medication. Follow lifestyle guidelines. So if the doctor decides that they want them to be on a different diet or something like that, that they're taking that seriously. Some of your complications can be things like your artery dissection, so perforation of an artery by the catheter. So this is something that can happen during the intra-procedure portion. It's where the physician, when they were going in, accidentally nicked the artery. So this can cause cardiac tamponade or require emergency coronary artery bypass surgery. So what will happen is they'll have severe hypotension, tachycardia. They're basically going into shock. Cardiac tamponade can result from that fluid accumulation in the pericardial sac. So this looks like hypotension, jugular venous distension, muffled heart sounds, paradoxal pulse, which that basically means that there's a variance of 10 or more in your systolic between your expiration versus inspiration. If you see these things, they come back from there and you're noticing these hypotensions or these jugular venous distension or these muffled heart sounds, you do want to let the provider know immediately because you may need to prepare the patient for a pericardiocentesis or return to the surgical suite. And this pericardiocentesis, all it is basically they get a big old needle and they remove some of that fluid from the sac. Hematoma formation, blood clots can form near the insertion site. So you want to monitor for your sensation, color, capillary refill, and peripheral pulses in the extremity distal. So you're making sure you watch that. You want to hold pressure for uncontrolled oozing and bleeding and notify the provider. Some of the other reactions can be things like allergic reaction to the contrast media, external bleeding, embolisms. So watching your patient's heart rate or if they're suddenly feeling that sense of doom. And with this external bleeding at the insertion site, make sure that you're keeping the patient's leg or arm straight and you're monitoring this site because it is an artery. So keep that in mind. Artery is all about that push. So you're going to have a lot of blood. So you do want them to adhere to these, keeping that leg straight. Acute kidney injury, damage to the kidneys can result from the use of contrast agents and that restenosis of the treated vessel. So like I said before, if they're not taking their antiplatelets appropriately, then that vessel can become, it can develop that stenosis once more. Next, we've got our retroperitoneal hemorrhage. So this is bleeding into the retroperitoneal space. So you can see this peritoneal, perirenal space here, and it's just bleeding that's going into there. So this is just the abdominal cavity behind the peritoneum. And this can occur due to a femoral artery puncture. So basically what happens is a lot of times they won't know that there's a retroperitoneal hemorrhage until after we've removed that sheath. So what happens is after we remove the sheath, we start seeing these signs and symptoms. So you just want to be aware of these. You want to see if there's any flank pain because basically all that blood's kind of pulling to the back near the kidneys. And you want to watch for hypotension. Immediately hold pressure at the puncture site and let the provider know and keep that leg straight. You want the patient to report any chest pain, shortness of breath, and cardiac manifestations. And just in general, one of the things that I always told my patients after we removed a sheath is if they have to cough, if they're going to laugh at a really funny joke, just tell them to kind of hold a little bit of pressure at the site, just so that way we're not popping anything, causing it to bleed more. The next thing we're going to talk about is your coronary artery bypass grafts. So this is an invasive surgical procedure that aims to restore vascularization of the myocardium. So it's all about kind of moving things in order for them to have a better blood flow. And I like this picture because it kind of shows a single, double, triple, or quadruple bypass. So a lot of times what you'll hear them say is they had a double bypass, or they had a triple, or they had a quad when they describe it in the notes. There's just a general overview. It's performed to bypass an obstruction in one or more of the coronary arteries, does not alter the atherosclerotic process, but improves the quality of life. So this isn't going to fix the way they have plaque, but it will help them to have a better blood flow. Most effective when the patient has sufficient ventricular function. So if they've got an EF greater than 50%. So if they see that there's going to be a potential problem, we want to get it with them before they have a very low EF. Older adults are most likely to experience transient neurological changes, toxic effect from cardiac medications and dysrhythmias. There are some less invasive revascularization procedures that have been developed to help reduce that risk and improve patient outcomes. So I'm not going to read through all of these, but these are basically just some of the potential diagnoses that will lead into us having a CABG. So this is our pre-procedure. So this is what we do before we actually get into the procedure. So it can be elective or emergency. Now, elective does not mean that your patient is like totally fine. It just means I've decided that I want to do my surgery a week from now. I'm stable enough that I can wait for a week. Emergency means we're taking them to the surgery suite right this second. You want to verify that the patient has signed informed consent, complete your baseline assessment of the patient's cognitive status, complete history, confirm recent chest x-rays, ECG, and lab reports. So back where I used to work, we used to do what was called courtesy calls. So a patient would come in the night before, and we would basically get all of this done before the patient would go into their open heart surgery. You want to administer preoperative medications, so prophylactic antibiotics, your anticholinergics, like your scopolamine patch, that can help reduce secretions, and sometimes those anti-anxiety medications. Ensure patient understands the procedure and the post-surgical environment. We'll talk about this post-surgical environment in the next slide. And then you want to assess the patient and family's anxiety levels. So patients actually have better outcomes when they're less anxious about their surgery. So you want to make them as comfortable as you can before they actually go in to have their surgery. So this is your patient education. So you want to make sure that they know the importance of coughing and deep breathing after the procedure. You want them to know how to splint, which that's basically just kind of, they hold a pillow over their incision when they cough and deep breathe. A lot of times after open heart, they get this little heart pillow, and they'll have like different people sign it. It's nice. You want them to perform their arm and leg exercises to prevent complications. So this is the thing that I say is very important to talk to your patients about. You want to let them know to expect these things post-procedure. Now, we don't scare our patients, but we just want them fully aware of what's happening. So immediately after, they're going to have an endotracheal tube, which is an EET tube. So this is going to have them where they have the inability to talk while that tube's in place. So just kind of knowing that they'll have that immediately after. They'll have a sternal incision and possibly a leg incision, because if they decide to take a vessel from their leg, they'll have that incision there. Early ambulation. So pretty much like Right after they get extubated, we're trying to get them up, we're trying to get them moving. So make sure they're aware that, hey, you're going to be walking soon after this. They may have 1 to 2 chest tubes, an indwelling catheter, pacemaker wires. So they'll actually have like a pacemaker that's external, and a hemodynamic monitoring device. So they may have what's called like an IJ. So they might have a line that's in their neck. So this is some more patient education, just letting them know that their medications may be discontinued. So things like diuretics, aspirin, or other anticoagulants may be stopped a week. Diuretics may be stopped 2 to 3 days before surgery, so that way they're aware. Some medications may be continued, or they may often continue for a cabbage. Things like your potassium, your antidysrhythmic drugs, your antihypertensive, metoprolol, insulin. So this is a very informative video. It's only about 5 minutes, and it just kind of goes through some of the coronary artery bypass surgery, things that the physicians do, and like that whole heart team does. So this is our intra procedure. What is your role? So if you decide that you want to go into surgery, these are the different things that you would do in surgery. So things like providing padding to bony prominences to promote comfort and prevent skin breakdown. So positioning is huge in surgery. You have to make sure that the patient is in the right way. Remember, we knock these patients completely out. Communicate surgical process to family if the physician wants you to. Assist in monitoring urine output and blood loss. Documenting appropriate surgical events. Assist in arranging intensive care unit placement and communicating with the patient's post-operative needs. So post-procedure, you want to maintain patient airway and adequate ventilation. So that's where we're talking about incentive spirometer, flutter valve, making sure they are breathing. During the intubated phase, allow family to stay at bedside if appropriate. So for a lot of these situations, if you have a patient who's intubated, and let's say they have like a balloon pump, or let's say that they're very restless, something's going on with them, they're very agitated. One of the first things you can do is just allow that family to come in, sit at bedside, talk to the patient. You want to dangle the patient's legs and turn the patient from side to side as tolerated within 2 hours following extubation. So that's what I was talking about. Within 2 hours, we're getting you up, we're moving you. The patient needs to get into the chair within 24 hours and ambulate the patient 25 to 100 feet 3 times a day by the first post-operative day. So what we used to have are these people in the step-down unit who would just walk the patients. So their whole job was just to walk the patients every day. You want to collaborate with the other team members for the patient care, case management. A lot of times they need to go to rehab afterwards. Assess and maintain pain control. Monitor hemodynamics. Watch for infection. So making sure, because they're going to have that sternal area and that possible leg incision. So resume sexual activity based on provider advice. So you want to talk to your patient about their concerns when it comes to sexuality. Don't make assumptions about it. And you just need to feel comfortable with asking these, especially if you decide that you want to work in a clinic. If the patient comes back after they've had open heart surgery, after they've had myocardial infarction, you just want to ask them, do you have any concerns about sexual relations? And look for those key things, because the patient's going to say it in a way that's very subtle. They may say something like, I don't stay in the same room as my husband anymore, or things have been different for me. You want to gather information so that way you can let the provider know. And make sure we're just letting them verbalize their feelings. It can be very scary after you've had a surgery like this. So you want to have that open communication. So our chest tubes. You want to monitor your chest tube patency and drainage. Measure the drainage at least once an hour, depending on the facility and the doctor's orders. Like it's once an hour, usually in critical care. Once they've gone to step down unit, a lot of times they'll move to the 2-hour mark. Volume exceeding 150 mLs per hour can be a manifestation of hemorrhage and should be reported to the surgeon. If the drainage stops suddenly and there is no evidence of kinks, fluid blockage, etc., report that to the provider. So if all of a sudden you are getting like a good 30 mLs per hour and now it's nothing, you want to let someone know because there may be some sort of blockage internally. Because you can see here, these are the typical chest tubes that you'll get post open heart. And you want to avoid any dependent loops in the tubing to facilitate drainage. So just make sure when you're noting how much you have for drainage that you're making sure to look that there's nothing kinking the line. Chest tubes, this is just like a general kind of information for chest tubes. They're used to remove air, fluid, or blood from pleural space, can prevent air or fluid from re-entering pleural space, reestablish that intrapleural and intrapulmonary pressures after surgery or trauma, and insert it into the medial sternum to drain fluid from the pericardial sac. Oops. So these are some of your complications. You can have pulmonary complications. It can be, I don't want to say simple, but it can be things like atelectasis, or it can be things that develop into even more serious problems like pneumonia or pulmonary edema. So the way we can prevent this is forcing our patients to walk, forcing them to talk. Now, I don't mean forcing, but highly encouraging them to do these things. While the patient is intubated, we're watching our suctions. So usually it can be every 1 to 2 hours as needed. Know your patient because you can both under and over suction. So just watching to make sure that you're looking at that. Turn the patient and advise them to get out of bed as soon as possible. Monitor your breath sounds and encourage them to cough, deep breathe, and use that incentive spirometer while increasing activities, reducing post-operative complications. The other complication they can have is hypothermia, which can cause vasoconstriction, metabolic acidosis, and hypertension. So you want to monitor their temperature, especially post-surgery. A lot of times right after surgery, a patient will come in kind of cold. You just want to make sure that they're not so cold that it's causing that metabolic acidosis. You may need to give vasodilators, and shivering is common following surgery. A lot of times they've got these warming blankets and heated lamps or heart lamps, heated lamps, sorry. Another complication can be cardiac tamponade. So this is that buildup of blood or other fluid in the pericardial sac. It puts pressure on the heart, which may prevent it from pumping effectively. So that's what the real issue here is, that we've got so much fluid through here, our heart's not able to contract the way we want it to. It can cause decreased cardiac output that can result from dysrhythmias, cardiac tamponade, hypovolemia, left ventricular failure, or MI. So with your cardiac tamponade, it results from bleeding while chest tubes are occluded. So this is why it's so important for us to see that our chest tubes are actually pouring out blood, because if they're occluded, then it's going to cause this buildup and cause cardiac tamponade. Increased pericardial fluid compresses heart chambers and inhibits effective pumping. Indications include a sudden decrease or just complete stopping of chest tube drainage following heavy drainage, jugular distension with clear lung sounds, and equal pulmonary artery wedge pressure and central venous pressure. So just making sure that you're watching your chest tubes and seeing that if it completely stops, then my next concern is going to be a possible cardiac tamponade issue. This here is just kind of like a helpful picture for it. Some of your other complications are things like hypovolemia, can result as a result of bleeding, decreased intravascular volume or vasodilation, hypotension, and decreased urine output. Left ventricular heart failure can occur with an MI or fluid overload. Your electrolyte disturbances. So potassium and magnesium depletion is common. So a lot of times they will come with standing orders where they'll have potassium, like if your potassium is this level, then you give this IV of potassium, so on and so forth. Neurological deficits. So transit hypertension, hypotension, or a blood clot may cause an intraoperative cerebrovascular accident. So immediate intervention if you suspect a stroke. Now, this doesn't matter if they came back from having a cardiac catheterization or if they came back from an CABG. If you notice that they're having slurred speech or confusion or any sort of neuro change, that is an immediate intervention. You want to do something about that immediately. All right, that should be everything. If you have any questions, feel free to email me. And as always, thank you.